So good morning all. My name is Oluyemisi Adeyemi-Fowode. I'm one of the faculty in the Division of Pediatric and Adolescent Gynecology here at Baylor College of Medicine. And this morning we'll be talking about Polycystic Ovary Syndrome, more commonly known as PCOS in the adolescent population. The goals for today's talk is to discuss the characteristics of normal and abnormal menses, and then I will move on to defining what PCOS is. I will touch upon the pathophysiology or the cause of PCOS very briefly. We'll then move on to how we as medical professionals diagnose PCOS, and finally we'll go over treatment options that are available. So before we get started, I think it's very important for us to go over what is considered normal menstrual cycle in an adolescent. We know that the median age of menarche, which also means the first menstrual period that you have, is about the age of 12 in the United States. We also know that cycles can be very erratic in the initial years following menarche or when you just started having your menstrual periods. We get a lot of referrals to our clinic to discuss abnormal or erratic cycles in the adolescent, and so it's very helpful that we have guidelines from the American College of Obstetricians and Gynecologists in terms of what is considered normal. So in this age group, having a menstrual cycle interval of about 21 to 45 days is considered normal. What that means is that you might have an adolescent who comes in saying, I have my period about every 21 days, or you might have an adolescent come in and say, I don't have a cycle every single month, but they still fall within that 45-day range, and so that's considered normal. We know that the menstrual flow length should be 7 days or less. Having a cycle that lasts about 10 days or 15 days of very heavy bleeding is not normal. And then as far as menstrual products use, this is very, it's based on the individual. However, what we say is that for soilage reasons, changing your pad or tampon about every 4 to 6 hours due to soilage is normal. So on average, you'd be using about 6 pads or tampon a day. If you're changing that more because of hygiene purposes, that's completely fine. But if you're having to use more pads than that because you're soiling through the pads or the tampons on your clothes, that's considered abnormal. So if we know that the menses in the initial stages can be erratic, what constitutes a menses that should require evaluation? Again, we're very lucky that the American College of Obstetricians and Gynecologists actually gives us some guidelines, which I've included in this slide here. So I'm not going to belabor the point because today we're going to be talking about PCOS specifically. What I would like to highlight is that PCOS workup can be started if you have cycles that occur more frequently than every 21 days or less frequently than every 45 days. And then if you have cycles that occur more than 90 days apart, even if that happens once, we might want to consider doing a workup. Another important point is that each patient is an individual. And so these are guidelines, and guidelines specifically, these are not rules. But these are some of the things that will make us decide if or not we should start evaluating the adolescent. There are lots of causes for having abnormal bleeding in an adolescent female, and here are some examples here. So pregnancy is one of the things that we need to rule out at all times, and then an immaturity of the hypothalamic pituitary ovarian axis. In simple words, this just means that when you first start your menstrual cycle, the signal that the brain is giving your reproductive system is not always fully developed, and that can take a couple of years to fully mature. Other reasons for having abnormal bleeding or cycles in the adolescent would be eating disorders or stress. And on the column to the right there, you can see other causes such as having thyroid issues or sexually transmitted infections or uterine lesions. Again, today we'll talk about hypoandrogenic anovulation, which an example of that is having PCOS or Polycystic Ovary Syndrome. That leads us to ask, what is PCOS? In easy terms, because it can get complicated, what it means is a condition that causes irregular menses because your monthly ovulation is not occurring. This is due to an hormonal imbalance because you have your ovaries making extra testosterone. And we know that it occurs in about 5 to 10% of reproductive aged women. So I think a diagram or picture is worth 1,000 words. So we're going to quickly go over the definition of PCOS with some pictures. So in the brain, you have two centers that are responsible for giving signals to your ovaries. We have the hypothalamus, which sends a gonadotrophin releasing hormone to your pituitary gland, which is also in the brain. Then your pituitary gland will send the hormones luteinizing hormone called LH or follicle stimulating hormone called FSH to your ovaries. This signals the ovaries to start to make other type of hormones such as estrogen, progesterone, and also testosterone. This is a feedback system, and so as your ovaries are making the hormones, not only are they communicating with your uterus or the lining of the uterus, but it is also feeding back to the brain saying make more or less of a particular type of hormone. If we look to the diagram on the right, this is supposed to depict what a regular menstrual cycle would look like as opposed to a PCOS cycle. So we know that in our ovaries, we have a lot of follicles or eggs that we're born with. When you reach the stage of puberty, what happens is that every single month, because of hormones that your pituitary gland here makes, the FSH and the LH, they either stay stable or rise. They change in terms of what the level is, and that is what actually triggers your ovary to ovulate an egg. The LH hormone is especially very important in the process of ovulation, which will happen about mid-cycle, and in a woman with the 28-day cycle, that would correspond to about day 14. In a PCOS cycle, you still have normal ovary with follicles in them, but you'll notice that the signals that the brain is sending to the ovaries is not exactly the same. So you're not getting this cyclical variation in the hormone level. Specifically, your LH or luteinizing hormone, which is very important in the process of ovulation, you do not get what we call that LH surge, which is a sharp increase around day 14 that actually causes you to ovulate. And so because of that, you're not having regular monthly menses. And so what causes PCOS? We're not exactly sure of the pathogenesis. However, what we do know is that genetics plays a very important factor. And so whenever we are considering the diagnosis for PCOS, we will ask a lot in terms of family history, in terms of women in the family, what their cycles were like, if they've been diagnosed with PCOS before. We also know that most, but not all women with PCOS are overweight or obese. And so we believe that insulin resistance has a very close association with the diagnosis of PCOS. And so the workup usually starts with an adolescent coming to the clinic complaining of irregular periods or cycles, and that can take a variety of forms. They might say every few months I'm having my period, or I'm not having periods at all. I had my first one at the age of 12, and now I'm 14, and I have not had any cycles in between. Or they may say I'm having frequent bleeding, and it's almost like I have 3 cycles or 2 cycles in a month. They might complain of having extra hair on their face or other parts of the body, called hirsutism. So this would be a female having male pattern hair, meaning they might complain of waxing or shaving the upper lip, the chin, the back, or the belly. Acne is also a very common sign because of the elevated testosterone. And then, as mentioned earlier, weight gain or trouble losing weight can also be one of the signs. Lastly, having patches of dark skin on the back of the neck or other areas, which is an indication of insulin resistance, is another sign that a patient might come up with. This slide right here is to give you an idea that multiple definitions exist for PCOS. It depends on the consensus guidelines that you're going with. And so not for it to get confusing, I'm going to just take all of that out. The important things to note on this is that you need to exclude other causes that might mimic PCOS. And not only that, but then you have to start to look at the characteristics of the patient. Are they complaining of oligomenorrhea, or in other words, some sort of abnormality to their menstrual cycle? Do they have clinical or biochemical hyperandrogenism, which again just means having signs of elevated testosterone, so things like the acne, the abnormal hair, when you look at their bodies? Or if you were to do a lab draw, do they have elevated testosterone in their blood sample? and then having polycystic ovaries on ultrasound scan. Right here, I just wanted to make the point that the Rotterdam criteria is what's most commonly used, especially in the adult population. What this basically says is that you need to exclude all of the causes, like we mentioned, and then after that, you need to have 2 out of 3 of this criteria right here. So either the oligomenorrhea, the clinical or biochemical hyperandrogenism, or the polycystic ovaries on ultrasound scan. And this is one that is most commonly used in adults to diagnose PCOS. But the diagnosis of PCOS in the adolescent is not as straightforward, and there are a couple of reasons for that. First of all, some of the signs could be due to just having normal puberty. For example, coming in after about a year of starting your cycle and saying, I don't really have regular cycles is not something that is always considered abnormal, as we talked about initially. And so having abnormal cycles, we have to ask a lot more questions before we decide if you're on the normal range because you're immature or if it's really a pathologic issue. The other thing we take into consideration when you think about clinical biochemical hyperandrogenism is a lot of adolescents have hormonal fluctuations. It's not unusual that they might have acne on their face, for example, and a lot of people will consider that as just normal changes that you go through in adolescence. So whereas it might be clear-cut in an adult, it's not always clear-cut in the adolescent. And then lastly, again, talking about the polycystic ovaries on ultrasound. I'm going to skip to this slide right here because we're talking about the role of ultrasound. And what a pelvic ultrasound helps us determine is it gives us a non-invasive way of evaluating the reproductive structures in a female, including the ovaries, the fallopian tube, and the uterus, and a small part of the vagina. Due to not ovulating every month in that PCOS cycle that we talked about earlier, you get lots of tiny cysts inside the ovaries. The ovaries then appear slightly larger. Now, this is a good criteria when you're talking about, again, adult women. But when you think about adolescents, what you notice is because, again, their physiology is a little different, and not all young women with PCOS will have polycystic appearing ovaries. Or you could actually get a subset of very normal adolescents who have cycles every month who have polycystic appearing ovaries. And so we don't think that that criteria of looking at the ovaries in an adolescent typically helps us with making the diagnosis. Another thing to note is that these cysts are not harmful and they necessarily do not need to be removed. So again, going back to diagnosis of PCOS in the adolescent, some experts will say that you need to have all 3 of this criteria, including excluding other causes, before you even make the diagnosis of PCOS. So just for us to summarize, I had talked about the Rotterdam criteria that is very helpful in adult women, taking into consideration 2 out of 3 of this criteria after you exclude other causes. It's not as clear-cut in the adolescent, and a lot of experts think that you should have all 3 before you give the diagnosis of PCOS. So to help us figure out the diagnosis, since it's not always clear-cut, some of the things we'll ask or some of the tests that your provider will get. During the history taking, we always want to ask you questions about your menstrual cycle. What age did it start in relation to how old you are now? How long does it last? So it's very important to make sure that you are tracking your periods, making sure that you are aware of the general health of the adolescent. Again, this helps you rule out other causes that could be mimicking PCOS. The family history is especially important because, like we talked about, genetics is strongly associated with PCOS. And so if you have a mom and a grandma who all have PCOS, and then you have an adolescent who's showing some of the signs and symptoms, it might clue you in to the fact that they could also have PCOS earlier than later. And then we would perform an examination, and this would include looking at the vital signs. You want to make sure that you're looking at the patient's blood pressure. You want to know what their weight for their height is, and to make sure that the body mass index is in the normal range. We're looking at the skin because we earlier talked about having dark parts or areas of the body that could clue you into insulin resistance. As far as pelvic examination goes, we typically do not need to do an internal exam to diagnose this in the adolescent, but certainly being able to perform an external genitalia exam is important because then that helps us to rule out some other causes as well. Afterwards, your provider might get hormone levels in the blood, checking what your insulin resistance is or how your body processes sugars. They might look into getting a lipid or cholesterol panel, looking at your liver test, and then we've also already talked about plus minus a pelvic ultrasound in the adolescent. PCOS is associated with other medical conditions such as obesity, insulin resistance or diabetes, lipid abnormalities, high blood pressure, increased risk of endometrial cancer and infertility, and we also know that there's an increased risk of anxiety and depression in adolescents that are diagnosed with PCOS. The treatment goal is not necessarily a cure for PCOS. What we tend to do is just manage the signs and symptoms. And so to summarize why we would want to treat, it's because we want to improve the clinical manifestations, we want to improve the patient's quality of life, and then of course also long-term outcomes. What can you do about having PCOS? The number one treatment for PCOS would be a healthy lifestyle. And so making sure that you're eating in a healthy fashion, making sure that you have daily exercise or a fitness plan, especially if your weight is out of the normal range for your height, is very important. And then making sure that you take the medication as prescribed by your physician or your healthcare provider. So targeting specific signs of PCOS. When we talk about treatment for abnormal menses, we talk about hormonal therapy. And what this means is having some type of estrogen-containing hormonal therapy, such as the daily birth control pill, the weekly patch, or a monthly ring. What this does is that it helps to correct that hormonal imbalance. You get a lower testosterone level, which we know that in PCOS, the testosterone level is elevated. It regulates your menstrual period. So if you weren't having a period every single month, there is a way that we can make that happen with the hormonal therapy. It lowers your risk of endometrial cancer. It helps decrease acne, and it also decreases the rate of hair growth. Even though we can't really do anything about the hair that is there present already, it will definitely slow down the growth and also new unwanted hairs. Talking about acne specifically, hormonal therapy can help with that, in addition to topical creams and oral antibiotics. In some cases, we work very closely with the dermatologist to make sure that we are addressing this concern for acne if hormonal therapy only is not working, or if oral antibiotics only is not working. Sometimes we use them in conjunction. For unwanted hair growth or hirsutism, hormone therapy is recommended. You can also use anti-androgen medications such as spironolactone. There are topical creams or other cosmetic options like waxing, bleaching, and laser treatment that are available. And then as far as having insulin resistance or prediabetes, there is the diabetic medication, metformin, that could be prescribed, and the purpose of that would be to lower your insulin levels. And a lot of times we use this in addition to hormone therapy. So again, these are all ways that we can help to manage the signs and symptoms. And then again, the most important part of this will also be having the patient at the center of all this, making sure that they are living a healthier lifestyle as possible. A lot of the questions we get center around infertility and concerns about infertility in regards to PCOS. So will PCOS affect my ability to have children? It's important to understand that women who are affected by PCOS have a normal uterus. They have healthy eggs in the ovary. And the reason why they might have a little bit more problem conceiving is because they're not having monthly ovulation. So every month when you get your cycle, it is basically a signal that you did not have conception that month, because if you were to get pregnant that month, then you would miss your cycle. So for women who are not having monthly ovulation, it is a sign that you are not ovulating every single month. And so it might take you a longer time to get pregnant than a woman who is having a regular cycle / a sign that she's ovulating every month. That being said, there are treatment options available, including medications that we give to help induce ovulation. And then with our our population, it is very important to stress that PCOS is not birth control, because you do not want to let an adolescent think, if they are sexually active, that because they have PCOS and they're not ovulating every month, that means they can't get pregnant. So this is something that we always stress. As far as weight management tips, we know obesity is a risk factor for PCOS, so it's very important, again, to make sure that lifestyle modification is at the center of any treatment plan that you have. So you want to choose nutritious meals instead of sugary or refined carbohydrates. Make sure you're eating a balanced diet, eating small meals and snacks throughout the day instead of large meals, exercising regularly, and again, maintaining that normal weight for your height or your BMI in the normal range. PCOS is a complex diagnosis, and it requires a multidisciplinary approach. And so I've listed just a few of the subspecialties that work together in terms of making a treatment plan or goal for a patient that will work. And so we work very closely with the pediatricians, as the gynecologist. In some instances, we would refer you to the endocrinologist, especially when we start to notice insulin resistance or pre-diabetes, working closely with a dietitian to help with maintaining a normal weight for your height, and also in terms of just helping you with your eating a balanced diet, having a psychologist, because we talked about increased risk for anxiety and depression in this in the affected adolescent population, and then most importantly, making sure that you include the affected individual in the middle of all that, because they're the most important whenever you're coming up with your treatment plan. Thank you so much for your attention.